Hereby I open this academic ceremony at Maastricht University. My name is Ton de Goey. I am the pro-rector of the ceremony and chair of this degree committee. First of all, I welcome Mrs. Lama Sultan. She will defend in public her academic thesis, which is entitled Palliative Care Education for Health Professions Students, an Interprofessional Shared Decision-Making Approach. Welcome all members of the degree committee, and I would like to welcome in particular two of the three supervisors. They are sitting in front of me, Professor Jascha de Nooijer. She is Professor of Interprofessional Teaching and Learning at the School of Health Professions Education at Maastricht University. And Dr. Nienke de Jong, she is Associate Professor in the Department of Health Services Research at Maastricht University. I will introduce the five opponents later, because if I mention all those names now, you will certainly forget. So I do that later. And I welcome the audience here in the aula and also all followers of the live stream, wherever they may be. May I ask you, Mrs. Sultan, to give a summary of your thesis? And I wish you success in the coming hour. The floor is yours.
Thank you, Prorector. Bismillah. Dear Prorector, highly esteemed opponents, respected supervisors, distinguished guests, my family and friends who are attending physically or virtually, thank you all for being here today. In the next 15 minutes, I will summarize my PhD thesis entitled Palliative Care Education for Health Profession Students, an Interprofessional Shared Decision-Making Approach. Let me start with a simple question. When we hear a storm coming, what's the first thing we reach for? We don't control the weather, but we prepare for it. In palliative care, our patients and family members are often walked through emotional, physical, and spiritual storms. And just like the umbrella, which offers protection without stopping the rain, palliative care offers support even when we can't change the diagnosis. So this idea inspires today's presentation, which is palliative care is the umbrella, not the rain. A long time ago, as you can see in the picture by Luke Field's painting in the 1891, the doctor painting, the patient was the center of the care, and the light was away from medication. And moving to the content of my presentation, I will explore the importance of palliative care, patient-centered care in palliative care education. I will begin with the introduction, followed by the research question, the planning model, key results and key discussion, and finally, the metaphorical framework of the interprofessional palliative care education for undergraduate health professions students. Well, due to the aging population and growing numbers of life-threatening illnesses cases such as cancer, the demand for high-quality palliative care services will consequently be rising. Palliative care aims to provide support to enable patients to live as actively as possible and to offer support to the family during the patient illness, which require a holistic approach. In Saudi Arabia, around 32,000 cases require palliative care per year, which was one of the key priorities of the healthcare transformation of our Saudi Vision 2030. Moving to the palliative care, palliative care requires a team of health professionals who work together. This team, including physicians, nurses, allied healthcare practitioners, who work with patients and their family members to support and improve the quality of life. And one of the foundational skills is actually assessing patients with decision-making. This can be facilitated through interprofessional shared decision-making approach. Due to the lack of interprofessional training during undergraduate education, this inhibits the preparedness for collaboration in such interprofessional teams. Our research aimed to deepen the understanding of the working process of interprofessional shared decision-making within undergraduate palliative care education aimed at contributing to the preparation of health profession students to work in interprofessional teams. The study was conducted at King Abdulaziz Medical City and King Saud bin Abdulaziz University for Health Sciences, which are both under the umbrella of Ministry of National Guard Health Affairs in Jeddah, Saudi Arabia. As you can see, the thesis is structured according to the David Kearns curriculum development model, providing a systematic framework for the research. There are six-step approach that are interrelated, which create a cohesive process. Starting with the first step, which is problem identification and general needs assessment, that lay the foundation, which require us to know what has been done in literature. Therefore, a comprehensive scoping review was conducted, and we ended up by reviewing 63 articles to answer this research question. What are the current trends in interprofessional shared decision-making for health professions education? The results include significant interest in teaching interprofessional shared decision-making when it comes to the knowledge, skills, and attitude among health professions, with the emphasis of an active learning method and the involvement of patient and/or family members. However, it shows a diversity in intervention duration, educational, and evaluation framework. Thus, there is a clear need to standardize theoretical framework and constant evaluation method. Study 2 and Study 3 assist the targeted needs assessment as a second step of the Kearns model. Research question 2, what is the feasibility of conducting interprofessional shared decision-making education to undergraduate health profession students in palliative care? In this study, a qualitative study design that captured the micro, meso, macro levels based on an interprofessional education of collaborative patient-centered care practice was conducted. The data collection included in-depth face-to-face interview with policymaker including deans of College of Nursing, College of Applied Medical Sciences, and College of Medicine, as well as the head of the Department of the Palliative Care, and a group discussion with the faculty member health professions and undergraduate health profession students. The results indicated a high demand for interprofessional shared decision-making in palliative care, and also the finding revealed factors that can facilitate or hinder the implementation. The facilitating factor including the relevance of the topic and the awareness of its importance as a systematic factor, and as a hindering factor, culture, religion, and gender. Institutional factor including structural challenge in curriculum integration, as well as issues related to the content and implementation, and issues related to the team member respect, hierarchy, and power issues. Research question 3, what are the perception and practice of faculty member, health professions, and students toward the interprofessional shared decision-making in palliative care? In this study, a cross-sectional study design was conducted and data was obtained through a self-administered online questionnaire that distributed to 459 participants with a 54% response rate. The questionnaire was conducted to explore the perception and practice of the topic and to indicate the associated factors. Positively influence the perception of the faculty and health profession by specific discipline and prior experience with interprofessional collaboration and shared decision-making. And the practice was positively influenced by discipline, teaching experience, and previous involvement with shared decision-making. Students, their perception was significantly affected by previous experience with shared decision-making and exposure to palliative care cases. And the only factor that linked to the student practice was their prior experience in palliative care. So as a key insight of this study, we found that there is high level of perception and low level of practice in the topic, and other factors that could be contributed or associated with the topic need further studies. Study 4 detailed the remaining steps of the Kearns model, which is setting a specific objective, align it with the educational strategy, and implementation, and finally, assessment and evaluation. So the research question 4, which is our last study, to what extent does participation on an interprofessional shared decision-making workshop in palliative care change undergraduate student perception about their practice and improve team performance? In this study, an authentic learning experience to practice interprofessional shared decision-making in palliative care among undergraduate students who attended a 3-day consecutive workshop with a cohort of 28 students was conducted, and a combination of their own assessment followed by the research as well as the evaluator with the team objective structure examination was conducted. The result shows significant positive change in student perception about their practice and improved team performance measured through TOSCI, but this is immediately after the workshop. So further study are needed to assess the long-term impact on undergraduate students' practice and performance towards interprofessional shared decision-making in palliative care settings. With that, we covered all the Kern's curriculum steps, and now let's move to the discussion. The thesis provides a structured exploration of key themes for interprofessional shared decision-making education in palliative care for undergraduate health profession students. We identify 4 overarching themes. The first theme, which is perceived value of interprofessional shared decision-making education in palliative care, and the importance of understanding context and cultural factors, as well as incorporating hands-on learning in the topic and advocating for team-based assessment rather than individualized assessment. The research has strength, which is including multiple stakeholders' involvement, such as deans, as I mentioned earlier, faculty, healthcare professionals, and students. It was structured according to a systematic framework, which is the Kern's model, and explicit integrated faculty or culturally sensitive aspect of palliative care, particularly in the last study, which is the case-based scenarios, and utilizing team objective structure examination, team OSCE. Limitation, including lack of generalizability, as this study was conducted only in a single institute with small sample size, and voluntarily participation biased, as well as in the qualitative part. And the assessment tool that was used in study 3 was originally developed for healthcare professionals and postgraduate students. Recommendations for further practice and research include the following. First, integrating interprofessional shared decision-making into curricula, especially for the undergraduate level. Provide faculty training and support in order to prepare them for this topic. Integration of other stakeholders, such as social services, psychologists, in order to mimic the reality of palliative care setting. And also recommendation, which is including multi-institutional studies. And for the research, patient outcome assessment, and the emotional preparedness for the undergraduate student in the topic, and utilizing technology, such as virtual reality in teaching and assessment in interprofessional shared decision-making in palliative care. To conclude with the umbrella that serve as a metaphorical framework for the undergraduate palliative care education for interprofessional shared decision-making, as you can see, there is the 5th themes that is really important for guidance of the healthcare professionals, which including collaboration, shared decision-making, hands-on training, cultural sensitivity, and assessment strategy. And the RAIN symbolizes the challenge and barrier that faced in palliative care education, including inadequate training, cultural factor, resource limitation, and communication barriers. The ground below the umbrella represent a positive outcome, and flower represent the stronger team collaboration, increased preparedness, and improved shared decision-making. The sun above the umbrella breaks through the clouds, symbolizing the potential for innovation in palliative care education for undergraduate health professions students. Thank you all for your attention, and I look forward to a fruitful discussion. And now, I respectfully hand on the microphone to the prorector.
Thank you very much, Mrs. Sultan, for a clear summary of your thesis. The opposition will now be opened by Dr. Desiree Joosten ten Brinke. She is Professor of Learning and Assessment at the School of Health Professions Education at Maastricht University. Professor Joosten ten Brinke, the floor is yours.
Thank you, Pro-Rector. Dear candidate, congratulations on this thesis and also congratulations for your supervisors. Your research explores a topic that is complex for many people, especially young people, palliative care. And you used various methods in your research and designed an interprofessional workshop to optimize interprofessional shared decision-making. And I also found the metaphor very powerful. And in a simpler expression than you showed in your last slide, we cannot stop the rain, but we can give people an umbrella. So very nice metaphor. And you have also illustrated this beautiful in your book. So impressive work. My first question is about the tension between universal standardization and local culture. In your scoping review, you argue for greater homogeneity and standardized theoretical frameworks in the interprofessional shared decision-making education. But at the same time, in chapter 3, you emphasize that in Saudi Arabia, specific religious and cultural factors determine decision-making. How do you see an international standard for the interprofessional shared decision-making that is consistent on the one hand, but on the other hand, for example, does not impose a Western model of individual autonomy on cultures where family-centered or hierarchical decision-making is the norm. How do you see that?
Highly esteemed opponent, thank you for your comments and for your question. And it's nice to start with this to just give a clear explanation. So when it comes to the palliative care, let us talk about palliative care. So palliative care is, everywhere it's the same concept. We want to improve the quality of life for patients and their families. And this is according to the WHO. So when it comes to the shared decision-making is part of the palliative care, because as you know, in palliative care, we need like decisions, very difficult decision in a sensitive situation, like withdrawing and with withdrawal therapy or use of, for example, opioid and other stuff. So these are it can be in international level. However, when we talk about the culture, religion, and context, it can be specialized to the area or the context. For example, in Saudi Arabia, as I mentioned, we have many tribes. So this is, although we are a society of a modern centralization, but however, these tribes really affect the family dynamics, affect the values, and affect the decision-making process. So again, it could be international. However, when it comes to the details, for example, in our study 4, we did like a customized case scenarios based on our culture or our needs.
So in general, there are standard
Yes.
steps. So there's the standardization you like to improve.
Yeah.
But within each step, we can see more diversity related to the context.
Exactly, yes.
Okay, thank you. Then I want to go to the part in which you have developed the workshop and also the TOSCI method. Your research showed that that workshop and the TOSCI improved the students' perceptions and performance. However, this is in an educational setting. And in practice, the team hierarchy and power relations are still major concerns. So how can we equip the students in their training, so in the education, so that their new skills endure when they enter a clinical environment in, where the hidden curriculum still exists? Maybe still the doctor is the sole decision maker.
Yes, thank you for this question. I will answer it in 2 parts. First of all, I will answer about the preparation and what we did in our TOSCI or the workshop, and then I will answer it in the debriefing part. So as you know that the simulation, we would like to increase the authenticity in the simulation, so we use the standardized family member. We train them, and actually they are part of the palliative care team. So they know how the patient and family member are dealing. So they mimic the reality. Okay, this is one point. And the other point, which is we structure the workshop according to the landscape of practice model. So this model includes a social constructivism approach, which each student from different discipline can learn from each other with 3 modes. So first of all, engagement. How can they engage with each other? And the other thing, which is understanding and the difference between how they deal, know each other roles, and then implementation. So this is what happened during the actual case discussion. Moving to the debriefing after the TOSCI, I know that TOSCI is a part of assessment, but however, we can use it as part of teaching. So in the debriefing part, first of all, we use the expressing their emotions, and then analyzing the same case, so they are all on the same page in terms of physicians, or medical students, in terms of nursing students, and in terms of the allied healthcare. So with that, they understand that they are all team for one goal. And then the feedback and the take-home message. So I guess we addressed this in our last study, which is study 4.
And are the students then also trained in a kind of strategic resilience, so that they can act on, in practice, on different attitudes towards the team, the interprofessional collaboration?
Okay. So let me answer this question moving back to our study 2, which is the qualitative part. Surprisingly, all the undergrad level students and the faculty, they all answered that there is some ego from physician or medicine. So we thought about this in our workshop to bring like an icebreaker at the beginning, and we did it as a game. So it's called the rug and balls. So just to break the ice that you are all here for one goal, which is the patient. And the patient was the rug, and all the balls were the healthcare professionals, and each color represent a part. So this breaks the ice through all the students, and then we go for an interactive lecture, and then the case discussion, and after that the TOSCI.
Okay. And so this is still in an educational setting?
Yes.
My idea is that implementing interprofessional shared decision making, that it also requires a fundamental change of working in practice.
Sure. Yeah.
What do you think is needed? What should be a next step based on your research to have this more strategic change in general?
Okay, so it could be by observation. So we, in our palliative care team, we have like the family meeting, we call it, or discharge planning. So maybe we can invite the students or undergrad student to watch this, or to be involved in the same table, so they can observe. So maybe learning by observation in this level, for the undergrad level.
Okay. For now, thank you very much.
Thank you.
Give the word back to the pro-rector.
Thank you, Professor Joost ten Brinke. The next opponent is not present here, but present online. Dr. Nouf Sulaiman Al-Harbi. She is Associate Professor of Medical Education at King Saud bin Abdulaziz University for Health Sciences in Riyadh in Saudi Arabia. Dr. Nouf Sulaiman Al-Harbi, the floor is yours.
Thank you, Mr. Pro-Rector. Dear candidate, I want to applaud you for all the hard work that you have done until today, of course. And thank you for addressing a very important area that can use more attention, especially in the context of Saudi Arabia. My first question is going to address the perception versus practice gap. Your findings in chapter 4 revealed a high level of positive perception among the students, but low levels of actual practice for IP SDM. How do you explain this discrepancy?
Highly esteemed opponents, thank you for your comments and for your question. Well, as maybe in Saudi Arabia, you know that palliative care is not incorporated into our curriculum. So for example, in undergraduate nursing, it's elective, and not all the nursing students choose to be trained or, have lectures in palliative care. And for example, in allied health, like the respiratory therapy, clinical nutrition, and occupational therapists that we're incorporating in our research, also, it's not included only maybe one lecture per block or one lecture in 1 year. And in medicine, we have it in the oncology part. So I guess it's from the beginning, we did not include in our curriculum a palliative care education, and then suddenly the students, when they are graduating or when they have to go to their internship, they see a palliative care cases. So, and they see it not only in, for example, a specific ward or a specific area. They see it among each departments, in medicine, in surgical, in pediatrics, in adult care, in home health care, but we are not really integrating the palliative care education. So this could be an explanation of the low practice level, but increased perception. Yeah.
Okay, my second question is about the barriers. You did identify hindering factors at different level, systematic, institutional, and teaching level. In your opinion, what is the most challenging factor? At what level do you see this factor occurring? And why do you think it is the most challenging factor?
Okay, so the most challenging factor, it could be integrating it into the curricula. So it's the meso level. That's why we don't have it in our institute, or in Saudi Arabia. However, we emphasize the importance of this palliative care. As you know, that the model of care in Saudi Arabia has one of the 6 dimensions, which is palliative care. So it's our role to advocate as an educator, to empower our healthcare force to teach or to be trained and to be competent in palliative care education. So I see that, yes, integration into the curricula could be the most challenging part.
My next question is about team versus individual assessment. You did, on one of your synthesis themes, advocates for prioritizing team assessment over individual performance. Yeah. And I want to ask, how do you propose addressing the issue of unequal participation within a team during high-stakes assessment? This is something we always face it with group work, and I would like to know your intake on it.
Yeah. Thank you for your question, and we face it as well too. So, and it's now still under study in the literature. But again, by team dynamics and by structured checklist could be helpful, like we use the PACT, patient assessment communication teamwork, which has 5 categories. How can the team work, and how the collaboration between them, the mutual respect. So it could be also a helpful part. Another thing which could be helpful is the peer assessment, or it could be the 360. For example, saying that patient or family members have to assess each team member and as a team as a whole. So this could be also a useful tool for assessment. But again, it's still under research and literature. Yes.
Mr. Prorector, do I have time for another question?
Yes, you have, sure. Please go ahead.
Okay. So my next question is about cultural and tribal complexity. Yeah. You noted that tribal diversity in Saudi Arabia adds a unique dimension to the IPE. First, I would like you to elaborate on that effect. I did not really get the complete picture, so if you elaborate a bit, and then address how do you think future curricula should prepare the students to address your explanation of the
Yeah.
tribal effect.
Yeah. Thank you for the question, and I don't want to repeat myself, but I will just state it clearly that Saudi Arabia, as you know, that it's a home of many tribes, and although society is modern and tribal affects continuous shaping our family dynamics, shaping our values and decision-making process, and also not only the culture, but also the Islamic factors. So for example, as the faith, family honor, dignity, and the will, which is in Arabic al-wasiyya. So all these integrating in the palliative care setting, and we actually integrated some of those concepts in the case-based discussion in the last study, which is the workshop, and also in the team OSCE. So I know that we have teach ethics to our students in the all level, but again, palliative care remain insufficient, unfortunately, when it comes to the ethical curriculum. So I think that we need to really address it more and properly in our Saudi curriculum.
I do understand when you say that as an ethical and a religious thing, but I still do not see the tribal effect.
Yeah, okay. Okay, so again, the tribal effect is affected by the family dynamics. So each tribes, for example, our research was conducted in a National Guard hospital, which is a military hospital. So we really have many tribes. However, we have a same value, for example, respecting family, respecting elderly, end-of-life care. Where do we want them to be at the place? Do we need a home health care for them? Do we need them to be hospitalized? So all these things affected by our tribes. Yes.
Okay,
You
again,
have,
I'm
you
gonna
have,
ask
if you like, you have
Dr.
time for another small question.
Small question. Okay, thank you. So I would ask about the professional experience of a clinician, a dietitian, and that's you, who is trained as a health professional education as well. How did this influence your role as a researcher?
Okay, thank you for
Was
the
there
question.
something that you would like to share with us?
Okay, so my background is clinical nutrition, and I was a clinician for 10 years. And then I moved to the education part. I want to empower others. I want to inspire others. So how can they be a competent, or how can they be a professional and a human? So in working within the team. So again, this experience gave me a lot to move from the clinical experience and to share it in the academia. With that, I'm very proud to this shift. Yeah.
Now the time is up, Dr. Al-Harbi. Thank you very much for your questions. I'll move on to the next opponent, Professor Rien de Vos. He is Professor of Education and Training, in particular Interprofessional Care, at the University of Amsterdam, and he is affiliated with Amsterdam University Medical Center. Professor de Vos.
Dear candidate, first of all, my compliments for your terrific dissertation, and also my compliments to your dissertation team. I would like also to compliment you about the metaphor of the umbrella and on its elegant and visual elaboration on the booklet. Very nice done. I would like to exchange some thoughts about with you. And in chapter 2, you conclude that although interprofessional shared decision-making education does exist, there is considerable variation, and the other thing is that it lacks clear frameworks. And in your dissertation yourself, you use several frameworks. It's the framework of palliative care, which you said is sort of universal around the world. The definition of shared decision-making as a framework. The framework of interprofessional collaboration, although I couldn't find the definition of that in your dissertation. And in chapter 5 is the TOSCI as an assessment framework. And I would like to ask you a number of questions about these frameworks. And my first question is about the framework of shared decision-making. And the background of that question is whether my understanding of shared decision-making is similar to yours, and if there is a difference, whether that is a cultural difference which I can learn from. And on page 11, you define shared decision-making as a process of integrating the best available evidence and the patient values and preferences, in which patients and caregivers discuss the goals of care, which is discussing and not decision-making. However, later on page 11, about 2/3 of the page, you write that family members and caregivers are responsible for making decisions when patients are unable to communicate due to their illness. And I wonder, what kind of decisions are you referring to?
Okay. Highly esteemed opponent, thank you for your comments and for your questions. Okay, so let me break it down and first define shared decision-making. As you know, that shared decision-making is the process of integrating the best available evidence and patient values, okay? So this is a patient-centered care and including the patient and the healthcare team, which is most probably the physician. These terms have been maybe mentioned in the 70s, okay? Or the 80s, yes, 80s. And then the interprofessional shared decision-making, which is incorporating different healthcare providers for the decisions of the patient. We provide them with the best available evidence and their best values or practice, okay? So this is the interprofessional shared decision-making, which is also come up in the early 20s. So again, the palliative care required decisions. For example, if we want to, as I mentioned earlier, withdraw or withhold therapy, right? The place of care, where do you want us to be at the end of life? Feeding, to feed or not to feed? Symptom control, what the kind of opioids or medication that the patient needs. So this requires a holistic approach, which include, for example, pain management, palliative care, nurse, dietitian, and so on. So this is the interprofessional shared decision-making. Moving back to the question of the models. So first of all, we wanted to create this curriculum. So the Kearns model, which is the planning model, we use it because it's a systematic, it's not linear, and it's based on the needs assessment, because in the scoping review, we couldn't find something related to our context, which is Saudi Arabia. So that's why the Kearns model, it's systematic, it is, has an outcome, and we can evaluate and then we can redo it again. For example, if we had this, we can go back to the objective and build on it.
I understand.
Yeah. I'm just explaining. Okay.
I very much agree with the framework you just pictured.
Yeah.
But my question was, what is the specific role of the family? Are they informants in decision-making, or are they decision makers for the patient?
Okay, sure. Again, according to the WHO definition, the palliative care is required a patient or the family member, right, to take care of them or to support them in this case. So, for example, a patient at the end of life, they couldn't be they cannot they are unconscious. So the family in our culture or in our context, they are the responsible spoken person to this patient. So that's why we address the family members in our study. And again, palliative care, not only for elderly or for adult, it could be for children. So this could be also benefit to the students that to learn that family member may be a part of the decision making. Yeah.
Yeah, they are part of the decision maker, but they are not the final decision makers for the patient when the patient cannot answer any questions. Is that?
But in our religion and in our culture, they are the legal guardians, and they are the one who
Okay.
are responsible.
Okay.
And the spoken person, we
Okay.
call them, yes.
I learned something new. Thank you very much.
No problem.
Which is a little bit different from the Western point of view. You mentioned that most of the decision making is about withdrawal of therapy kind of things.
Yes.
And would that make the physician the most prominent decision maker?
Okay. Okay, so for that, again, as you mentioned, yes, it's right. Sometimes with therapies, the physician will be responsible, but again, a multi, or as we call it, a family meeting will be conducted, and it has to have at least two consultants, which are physicians, and a documentation, of course, for that. This when it comes to withdraw and withhold therapies, like chemotherapy, radiotherapy, and so on.
Okay.
Yes.
Thank you very much. I would like to switch to teaching. And teaching shared decision making comprises a number of teaching competencies to students. And reading your dissertation, I just realized at that moment that there might be a considerable overlap between the competencies necessary for shared decision making and interprofessional competencies. And I would like to ask you, is there an overlap? Where is the overlap and where is no overlap? And they are distinct teaching issues.
Okay. So
You
I
may
totally
give
agree.
a short answer, please.
Okay, sure. I totally agree that in shared decision making, it is an overlap of competencies, including collaboration, because collaboration comes with multiple healthcare providers. Communication comes with the healthcare provider and the patients or the family member, and also advocacy, being an advocate for the patient, including in the shared decision making. So as you mentioned, that it's a combination of many competencies, including advocacy, communication, and collaboration. Yes.
Okay, thank you. I return the floor to the prorector.
Thank you very much, Professor De Vos. The next opponent is Dr. Danielle Verstegen. She is Associate Professor at the School of Health Professions Education at Maastricht University. Dr. Verstegen.
Thank you, Prorector. Dear candidate, I would like to add my congratulations to all the congratulations that you've already heard to you and your team. As you may know, I've worked on education for palliative care in the undergraduate medical curriculum in the past, so I recognized a lot of the things that you wrote about. And you've managed something that we've never managed, to make this an interprofessional education, so my congratulations on that. One of the returning discussion points that we had in our team was, when should we start this education about palliative care? It's complex, it's emotional, it's difficult. So we found that many teachers said, well, wait a little bit. Let them mature, let them first learn how to deal with many other things, how to deal with being a professional, and then start with palliative care. From an educational standpoint, I think we were more in favor of starting early and integrating it longitudinal. And we also found that the students wanted it earlier. So my question to you is, if you were to decide, when would you start education on palliative care and shared decision-making in palliative care? And how would you integrate it in the curriculum? Would it become a separate course or somehow a longitudinal effort?
Highly esteemed opponents, thank you for your comments and for this important question. In our thesis or in our studies, we incorporated into the undergraduate level in the clinical phase. So after they have developed their professional identity, so this becomes before the internship. And I guess that it's very important to incorporate it in undergraduate, not in postgraduate, because as you know, that knowledge is very easy to grasp within a second, but however, teaching these soft skills or important skills and how to deal with it, and to be to have a culture of a teamwork and shared decision making is still, important. So in undergraduate level, it's more important. For example, if we leave it onto the postgraduate, maybe they will be overwhelmed, or they will have like burnout or so on. So I think as early as possible to change behavior. It's about learning and changing behavior. So it's early as possible in the clinical phase. And the other question, which is how to integrate it. So I guess maybe by each faculty, they can address this important topic when it comes to the knowledge, and each faculty, for example, students or discipline know about it, and then the skills and attitude come later together. For example, addressing the roles and responsibility for each discipline, it can be individualized, and then we have them all together as a case-based or a workshop. It could be helpful, yeah.
But I understand that you clearly want to wait until the clinical phase and not before.
Yes.
And why is that?
Maybe I'm not sure if our curriculum is the same of yours. So the clinical phase, it's in the for the medicine students, it's in year 5 and year 6, which is before the internship. Mm-hmm. And in allied health and nurses is in 3rd year and 4th year, before the 5th year, which is the internship. So these 2 years, I guess we can address the interprofessional shared decision making for palliative care. Yeah.
Yeah, I think we should have a discussion, because I'd like to
Sure.
challenge that. We worked on actually introducing this topic also in the theoretical part of the curriculum.
Yeah.
To install the idea that, at least the estimates are correct, maybe a large part of the patients will not really cure.
Yeah.
Okay. Let me ask you a different question.
Sure.
In your thesis, it's very clear that you think it's important to understand the cultural context when you design education.
Yeah.
Now, I understand that you might want to change the case that you have in assimilation training and adapt that to the context. I was wondering, did you also change the way that you approach education, the educational strategies that you use, the way that you teach? Is that also dependent on context? And if so, how?
Yeah, okay. So if I will talk about our workshop, we did not only include case discussion. So first of all, as I mentioned earlier, it was a game just to break the ice, and then it has we have an interactive lecture, and then a role play, and after that, the case-based discussion, which was the main teaching tool. And then the team objective structure examination. So again, according to the objective that, for example, each one wish, we will integrate it to the teaching assessment, align it, and then align it with the assessment method. So teaching interprofessional collaboration in palliative care could be, as I mentioned in my recommendation, through digital, as we are in the era of digitalization. For example, utilizing virtual reality. And it's very easy to make decisions by the virtual patients. And it could be also enjoyable for the participant or the students, because it's a tough topic and a sensitive topic. So it could be also helpful.
But let me take that one step further. That setup where you start with an icebreaker and interactive lecture. If I were to do something here in the Netherlands, could I use the same structure and just change the patient case that we discuss? Or would I change more?
Okay. So it's according to the resource that you have. For example, in our institute, we have like a big simulation center that can we utilize. But maybe in your setting, I'm not sure if you have, for example, a simulated center, like a manpower who can run this simulation center, or maybe you can use like virtual reality. So it's, again, according to the resource that you have and the utilizing for the resource, and according to also to the number of participants or the students, and to the specialty. For example, in Jeddah, maybe in Riyadh they have pharmacists, but in Jeddah we don't have pharmacy college. So again, it's according to the like the target audience, the number of the target audience, the resource available, and the faculty. Are they trained or no? Yes.
Thank you so much.
Thank you.
I have a last small question that might be a bit challenging. You talk about the cultural context of your training. I think that also implies a lot for how people communicate when they are involved in shared decision making. Now, you've been in an international PhD team. How did you handle cultural differences in your own team?
By respect. Okay, it was very smooth and respecting each other, knowing open communication with respect and understanding each other. So yeah, that's it, I think. Yeah.
Well, forgive me for my difficult question. I'm giving the word back to the prorector.
Thank you.
Thank you, Dr. Verstegen. The fifth and last opponent is Dr. Jill Whittingham. She is senior teacher and director of undergraduate bachelor health sciences program at Maastricht University. Dr. Whittingham.
Thank you, Pro-Rector. Dear candidate, ahlan wa sahlan. Also to your family.
Thank you.
I will continue in English,
Okay,
just to be sure. And the rest of the room can follow. I would like to join the compliments. First of all, for you, for your hard work and your team, for taking on board a very difficult and challenging topic, I believe, but a very necessary and a very important one to take on board. Not alone emotional norms and values, but also different disciplines, and I think that relates very well to the scope of your interprofessional education. I think from a health perspective point of view, if we look at it from a very historical point of view, researchers in the past have spent a lot of time and effort to promote health and to make sure we are as healthy for as long as possible. And I think now it's also very, very important to take on board what palliative care, end of life, and how do we deal with that. So again, I underline the importance of this. I would like to take you on board in one of my challenges. As was mentioned, I coordinate a bachelor program, Health Sciences, which trains not necessarily clinicians, more professionals who will deal with preventive research, policy making, design of health system care. Those general themes are very important to our students. I believe palliative care could be a very good topic for that. And more specifically, I'm interested to ask and to discuss together what competencies, based on your experience and research, would you like to give back to the health sciences students? So what sort of competencies would you like to return, or would you like me to take on board for these specific students?
Highly esteemed opponent, thank you for your question and for the comments, and shukran. Okay.
Afwan.
Okay, so in regards to your question, I guess humanity is very important. As you can see in the painting that I just put it in the second slide, I was inspired by one of the keynotes speaker in a humanity conference about medical education in our institute in Saudi Arabia. And this really inspired me because, you know what, when I saw my patient after I finished from any intervention, they said, thank you for your humanity. And it's really touching. And not for me but also for my team. So teaching humanity is very important, and I think it's also related to the palliative care education. First of all, you have to be a role model. So being a role model as a healthcare professionals, either in dietitian, respiratory therapy, nurse, or physician, it's really important for our new generation and the healthcare force, future healthcare force, and it's also important for palliative care. Again, knowledge is very easy now to get with a 1 second, but teaching those valuable skills is really difficult, and it's important too. Yeah.
Do you have any specific, I read about your workshop. Do you have, aside, for example, the workshop, do you have other, maybe came across different educational activities where you're like, could take that on board for a curriculum to work on these? Because I agree, knowledge is one thing, and maybe the easiest thing to achieve. Values like humanity are much more challenging. So what are learning experiences I could design for my students to work on aspects like these?
Okay. In palliative care or in general? In general.
Yeah, I would say palliative care,
okay.
because I think that's a very
Okay, so let me answer this question with a story. When I was in the clinical nutrition department for 10 years, the palliative care rotation in the dietitian was elective. So many students or interns, they don't want to come to the palliative care, but they said, we want to learn from you. So it was very challenging for me. So what did I do? I did 360 videos from the scratch to mimic the reality of the palliative care, and then have them see it in the virtual reality. So they can know what is actually in virtual reality. But this was maybe 7 years ago, before I did my PhD. Yeah, and again, I taught them there how to be a communicator, how to be a collaborator, how to be a part of the team. So if they wear the goggles, they sit in the discussion table, and also they see breaking bad news with the family member or the patient. So utilizing technology, I guess it's very important, also to teach soft skills. Yes.
Okay. Well, I will have a discussion with one of my colleagues. If I am allowed to have another question, I would like to take you also to one of my other things I do is have a collaboration with a medical program or a medical curriculum in the Kingdom of Saudi Arabia. And that is a medical curriculum. And as you are well aware, that is linked to your own national framework of doctors, but also what is possible and impossible. And I would like to, I think, close this session in a minute, would like to move to a wish. What would you like for a medical curriculum in your kingdom to take on board? And I know you will be limited in different ways, but what would be your wish, given your topic and your research, to include in a medical curriculum? And I will be sure to take that on board in my conversations with them.
Okay, thank you for this important question. So I wish a culture of collaboration and teamwork, especially in palliative care. Palliative care, each discipline has the same importance. Physician, nurses, allied healthcare. So creating a culture of a teamwork, we all important for one thing, which is patient-centered care. This comes with teaching or even with assessment. So I wish for that. And also, 2 wishes, sorry for that.
Go ahead.
And I was thinking about it to take it in a national level, which is train of trainer, TOT, not in teaching and assessment or simulation, but also in interprofessional learning, interprofessional training. So I was thinking about this wish, and I hope it become reality, to train our faculty and healthcare professionals to teach interprofessionally, to assess interprofessionally, and to have this culture of teamwork in healthcare. Yes.
Can I follow up on that? Because I can relate to the wish of a culture where teamwork. But to get there, we need specific skills and competencies of that teamwork. Again, what can I bring to these students? This is, in this specific case, already a student-centered curriculum. So these students are already making a little, well, not a little, they're making a start in collaborative learning, working together. Still, I wouldn't say they reach full interprofessional learning. So would you have a final
Yes, Mr. Sultan, as you see and hear, the time for defending your thesis has passed, so we don't have an answer from you. Maybe you can discuss that later.
We will.
I think so. The degree committee will now withdraw to discuss the quality of your thesis, and in particular the quality of your defense, and please await our return here.
Thank you.
This is Lama Sultan. The degree committee here has assessed the quality of your thesis and also, in particular today, also the quality of your defense. And in view of this positive verdict, and also taking into account the examinations that previously have performed by you, the committee has decided to grant you the degree of doctor. And Professor de Nooijer is authorized to confer on you this academic distinction in accordance with Dutch university custom and law. Professor de Nooijer.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I promise.
By the authority vested in us, by law and in conformity with the decision of the committee here present, I hereby confer upon you, Lama Sultan, the degree of doctor and grant you all the rights attached to the custom and law. As evidence of this, I now present you with a degree certificate signed by the rector, the secretary and the other members of the committee and affixed with the official seal of the university.
Dear Dr. Lama. Yeah. Dear Dr. Sultan, dear Lama, after 5.5 years of hard work and a fantastic defense, you may now proudly call yourself doctor. Congratulations. This comes also on behalf of Professor Yasha and Dr. Bazim, who is joining online. We are extremely proud of you, and now it's time to relax, to celebrate, and perhaps even to dance, maybe singing, because this achievement is more than well deserved. But before we move on to dancing, etc., and everything that follows, there are still a few small things we need to reflect on, Dr. Lama. Yeah? Foremost, I would like to thank you for choosing this topic as the focus of your work, palliative care, education for health professions, students. This is not only an important topic in Saudi Arabia, but one that's highly relevant worldwide. I'm very grateful for the work you have done on this topic, and I truly hope that you continue this important work and ensure that palliative care becomes an integral part of the education for all healthcare students. Let's take a walk through the past 5.5 years. You began your PhD journey in July 2020. And as you describe it yourself, see page 112, 113. It was a journey filled with storms of doubt, stormy nights of uncertainty, heavy rains. Now you saw it yourself. The entire weather forecast passing by. Was it really such a rainy affair? In your perception or experience maybe. And yeah, the question is, did we experience it as a rainy adventure as well, we as a supervisor team? And I will answer this question. In your work, you're highly structured. Every month we had an online meeting and you were always well prepared. And with this way of working, you managed to tame the weather and keep things dry, in our opinion. Perhaps there were occasional storms after receiving extensive feedback. But after each round of feedback, you always got back to work with renewed determination. A storm turned into strong wind, then into a gentle breeze, and finally into a calm, sunny day. Sometimes you were a storm yourself, speaking so fast and improving the text at lightning speed, rakatakatak. So we advise you to always remember to keep your calm. Yeah? Okay, we really appreciate that you continued your PhD without complaint, tackling each challenge with such good spirit, and what a good spirit you had. You were always happy to see us, always with a laugh, and your positive attitude really deserves a compliment. We did not only see Lama online, you also visit Maastricht several times, and you had the opportunity to meet Professor Jascha at several conferences. And these in-person encounters added an extra dimension to our collaboration. And it was always a pleasure to connect with you face-to-face as well as virtually. Sometimes we wondered how you managed to do it all. Your PhD, you have a full-time job, and every time we spoke with you, you had already led 2 or 3 trainings or workshops. So that's a huge amount, number of sessions. It's really impressive how you kept everything organized and on track. Of course, running all these trainings was important to get the work out there, but still it's amazing that you manage it also smoothly. But I want to address a final issue, and it is very serious. It is an important point that we still haven't received an answer to, isn't it? Yeah, of course we have been speaking with you online for 5 years and a half now, and everything went wonderful. Sound was working, etc. Picture, cameras, okay. Everything went wonderful. But at the end of every single meeting, Lama always took a screenshot of us, or sometimes even a picture of us. So the question is, why? Were you trying to capture our age? Our clothing style over time, or something else? We have no idea. So we would really like an explanation, not now, but what did you do with all these pictures and screenshots? Maybe you can clarify it at the reception later on. Yeah. Dear Lama, you have brought this to a wonderful conclusion, and we are truly impressed by how you have managed it alongside your very busy job and raising your son. We would also like to extend our congratulations to your husband and your son, and of course your parents, other family members and friends here, and those who are following the ceremony online. You can be very proud of what Lama have achieved. Lama, at this moment, it's not raining, as it does on the cover of your book, or elsewhere. For you, the sun is shining, and it is time to celebrate. It was a pleasure working with you, also on behalf of Professor Jascha and Dr. Basim, and we will miss our monthly meetings. But I'm sure you will stay in contact, and for now, we wish you and your family and friends a pleasant day, and hope you enjoy your stay in the Netherlands.
Esteemed Dr. Sultan, dear Lama, I congratulate you with your doctorate, and I do that also on behalf of Maastricht University. And although it's difficult to add something after this wonderful laudatio that you just got, I would like to put some emphasis on several aspects in the last hour. Well, one of the compliments that I want to give you, and not only you, but also your supervising team, is your summary of your thesis was very clear. And that presentation is meant for non-experts. And I think and I hope that people here in the audience and also in the live stream have understood what you did the last couple of years in being away from home, doing a lot of work, having some stress sometimes. So I hope that it would be very understandable for you what has been going on and what has come out. So congratulations to you for that, but also for your thesis. The committee did read the thesis with interest and with pleasure. And also we have seen that, well, you have a thesis that is focused on not an easy issue. It is rather a complex issue. And it has also been done with, you have performed the studies with good approaches. And with respect to your defense, we have seen that sometimes you had really some challenging questions, I think. And in my opinion, sometimes you were really also asked, what should you do in that or that situation? This is not easy, but you managed very well in answering. We are very satisfied with your defense of your thesis. And my congratulations are going, of course, to your, not only to you, but your three supervisors, Professor Jascha de Nooijer, Dr. Nienke de Jong, thank you for the laudatio, and Dr. Basim Al-Saywit. I would like to include in my congratulations, of course, also your family, your parents, your husband, and your little son. He's going around, I think. Oh, he's right there. So congratulations, and I hope you have also enjoyed the ceremony. I would like to thank the committee for critically reading the manuscript. Maastricht University appreciates your contributions, and in particular, Maastricht University thanks the external members like Professor de Vos and other external members of the committee. And before I close the ceremony, I would like to invite your co-supervisor, Dr. Basim Al-Saywit, first to congratulate the young doctor. Dr. Al-Saywit, the floor is yours.
Thank you so much, Mr. Chairman. Ladies and gentlemen, distinguished faculty, colleagues, family members and friends. Today, we celebrate a remarkable milestone, the successful PhD defense and graduation of Lama Sultan. This is not a moment of academic achievement, but a testament to her perseverance, resilience, and her excellence. Over the past 5 years, and even a little bit more, I guess, Lama has demonstrated an exceptional dedication, intellectual rigor, and unwavering commitment to her research and academic job. The PhD journey was never an easy one, to be honest. It demanded a huge amount of work, patience, discipline, and courage, which persist throughout sometimes uncertainty. Lama has met every challenge that she faced during her PhD with absolute professionalism. She was mature, well-prepared, truly admirable work ethics, I have to say. What set Lama apart from others that not only her academic competency, but also her integrity, her initiative and innovative ideas, and the way that she creates presentation and her communication skills was absolutely 10 out of 10. Ability to translate ideas into really meaningful actions, I have to say. I don't know, she has a superb performance. But her critical thinking process was really clear, with a very strong sense of responsibility, juggling several things at the same time, at the same point, and not only juggling things this way, but only with excellence, also with excellence, and an amazing performance. As her supervisor, I was really privileged to witness her growth from a supervisor of her master's degree to a co-supervisor of her PhD degree, from being a passionate student to an independent, confident researcher. I'm really proud of what she has accomplished, and even more proud of her as a person, as a friend, and as a scholar to become. Please joining me in congratulating Dr. Lama Sultan. Thank you so much.
Thank you.
Thank you, Dr. Al-Sawit. I give the word to Dr. Nouf Sulaiman Al-Harbi.
Assalamu alaikum. Congratulations, Dr. Lama Sultan. I'm really very proud to see an alumna of our own Master of Medical Education achieve her PhD. It's such a huge milestone. I just want to say this is the beginning. Congratulations again. Thank you, Mr. Parker.
Thank you very much for your congratulations. Before I close the ceremony, I have one remark. Just after completing the ceremony, we will take a picture with you in the middle, with our other members online on the screen. So we take first and the photograph here. And I would like to ask the close family, and I think that's almost everyone here in the aula, please stay with us, because I would like to invite you to join us for the second picture here. And after closing, we go to the hall, and there at the stairs we take another picture. But in particular, we take the picture here because then we have the other members on the screen. Hereby, I close this academic ceremony.